Hello and welcome to our LSVT Global webinar, Myths and Truths about LSVT Loud and LSVT Big. My name is Beth Peterson and I'm joined by my colleague Laura Gousset, and we'll be presenting here today. Before we get started in the webinar, we do like to acknowledge our funding support, which has helped make these treatment programs possible and what they are today. We've had funding support from the National Institutes of Health, the Michael J. Fox Foundation, the Parkinson Alliance, and the Davis Phinney Foundation. I'm going to briefly go over the plan for the webinar so you know what to expect. First, I'll cover some logistics, and then I'll do a brief introduction of myself and Laura so you know who's speaking with you today. And then we're going to discuss the scientific rationale, the evidence, and the treatment protocols for both LSVT Loud and LSVT Big. And then for the second half of the webinar, we want to spend a lot of time clarifying some common myths or misconceptions about these treatment approaches. And then we should have some time at the end of the presentation to address any questions that you may have in the audience. So to start with the logistics, right now everybody in the audience, your microphone is automatically muted, and that's just to make sure that we don't have background noise from the various environments where you may be joining us. But if you do have a question during the webinar, there are a few ways to ask your questions. The first is to raise your hand. You can do that by clicking on the hand icon on your webinar control panel. I'll then see that your hand is raised, and I'll call out your first and last name to let you know that I've unmuted your microphone, and then you can ask your question out loud to the group. The second way to ask a question is to type in your question, and you can do that by clicking on the question box on your webinar control panel. Then you can type in your question. I'll see the text of your question and I'll ask it out loud to the group, and either Laura or myself will respond that way. And the third way, and this is really at any time, is to email us, and I'll put up that email address at the end of the slideshow, but it's info as in information, so info@lsvtglobal.com. Then I also wanted to mention the handout. So I don't think we were able to get an email to you ahead of time with that handout attached, but it is attached to the webinar control panel. So if you click on the handouts tab on your webinar control panel, you'll see a link to that handout. If you click it, it will open up in a website browser, and then you can either download it or view it on the screen there, or go ahead and print it, and so you have access to that handout. We'll also send a follow-up email after the webinar, and we'll attach the handout in PDF format to make sure that everyone is able to access that handout. So I'd like to just briefly introduce myself and Laura. As I said, my name is Beth Peterson. I'm one of the LSVT Loud faculty instructors. I'm a speech language pathologist. I'm also the Chief Technology Officer with LSVT Global, and I've been a part of the clinical research team with LSVT Loud, where most of that research is conducted at the National Center for Voice and Speech in Denver under the direction of Dr. Lorraine Ramig. I'm joined by my colleague Laura Gousset, who's a physical therapist. She's one of the LSVT BIG faculty instructors, and she's also the Chief Clinical Officer for LSVT BIG with LSVT Global. So we're both very excited to be joining you here today to talk about some of these myths and misconceptions with the treatment approaches. For disclosures, all of the LSVT Global faculty have both financial and non-financial relationships with LSVT Global. The non-financial relationships include a preference for LSVT Loud and LSVT Big as treatment techniques. Both myself and Laura are employees of, and we receive lecture honorarium and travel reimbursement from LSVT Global as faculty for the LSVT Big and LSVT Loud training and certification workshops. I'd like to go over the objectives of the presentation today. We hope that you'll be able to explain advances in neuroscience and the impact on the field of rehabilitation after the presentation today. We also hope you'll be able to discuss the development and the data on the efficacious behavioral treatments we'll be discussing, LSVT Loud and LSVT Big, and then also be able to explain common misconceptions about both of these treatment approaches. So I'm going to turn it over to Laura, who's going to start with our kind of introduction to these treatments and where we got started and what motivated us. And then we'll continue on with our presentation today.
Thank you, Beth. And I just wanted to go back to the title of today's webinar. It's entitled Myths and Truths about LSVT Loud and LSVT Big. And truly, we want to present both. And so I would call this section of our webinar the truths about LSVT Loud and LSVT Big. And so with that theme, I think it's important to just discuss where rehabilitation is today for persons that have Parkinson's disease. And we think it's a really great and exciting time to be in the field of rehabilitation. Certainly, we're still interested in being part of finding the ultimate cure for Parkinson's, but in the meantime, it's exciting to recognize the advances that have been made in the last 2 decades in regards to the importance of exercise and its role in symptom management in Parkinson's disease. If you go back a couple of decades ago to the 1980s, at that time, there really wasn't much evidence for the importance of exercise in people with Parkinson's disease. And so classically, when patients were diagnosed with Parkinson's disease, they were given little to no information about what type of exercise they should do, and rarely a referral to therapy unless something devastating happened, like a loss of function, a fall-related injury, need for assistive device, or severe problems with voicing, with communication, or perhaps swallowing. And patients were sent home with medication. So in the late 1980s, LSVT Loud was developed, and it was very groundbreaking to develop a treatment to improve voice and communication in persons with Parkinson's, where before it was thought that couldn't help. And that was really in the days before we understood the changes that could be made in the brain as a result of intensive voice and body exercise. And so now we really recognize that science has caught up with our clinical outcomes, and we not only recognize how valuable exercise is for primary symptom management in Parkinson's disease, we also realize that there are specific principles of exercise that drive what we call activity-dependent neuroplasticity, or the brain's ability to change. All of that exciting research has led us to this idea that exercise is like medicine. It has a very, very potent effect on our function and may also slow disease progression in Parkinson's disease. Next slide. So because of all of this scientific literature, voice and body exercise, including the LSVT Loud and LSVT BIG protocols, have been really elevated to an equal platform with pharmacological treatment and neurosurgical treatment for Parkinson's disease. So no longer is it one or the other, but now we realize that for patients to be truly optimized in terms of their symptom management, it's important to have optimal pharmacological care and perhaps neurosurgical care like DBS in combination with optimized voice and body exercise as a prescription, just as your doctor would prescribe something like Sinemet for your Parkinson's disease. So we want to show you a video, and you might have seen this video once before. It is on our website in case you want to share it or watch it with someone else, but you can go to the next slide, Beth. It's a stunning video, and Beth and I have seen it probably hundreds of times and really never get tired of seeing Shirley. Shirley just really reflects this point that a person with Parkinson's has so much potential to improve even after medication is optimized. So in her case, she was 2.5 years post-diagnosis, and she was optimized on her medication. Yet she was having difficulties with her voice and speech, and people were having difficulty understanding her. So she sought a referral and was seen by speech therapy for this specialized treatment technique called LSVT Loud. It's a 4-week treatment protocol that's quite intensive and works on amplitude or loudness of the voice in a very structured and specific way. So here is the video of Shirley. You're going to see her in an interview before LSVT Big and Loud, and immediately 4 weeks later at the conclusion of her LSVT Loud. Go ahead and play it.
Have you noticed any changes in your speech or your voice that you would associate with Parkinson's?
Yes, I don't speak loud enough a lot of times.
Anything else?
Hoarse.
Anything else?
I stutter, which I never did before.
Do this for me if you would. Take a deep breath and say ah for as long as you can. Good for you. Okay. Would you say Parkinson's disease has caused you to talk less?
Yes.
Because?
Because I stutter and then I can't be heard. If there's noise in the house, like when the kids come over, nobody pays attention to it because they can't hear me. Till I get mad and then yell.
Take a deep breath and say ah for as long as you can. Have you noticed changes in your speech or your voice as a result of the speech therapy?
Oh, yes.
What have you noticed?
I talk louder. I think louder. I'm going to sing with the Sons of the Pioneers one of these days with my voice.
Good for you. That's excellent. What practicing do you do at home?
My ahs, my highs, and my lows. And I read out the mail out loud.
Excellent. Do you feel like practicing helps?
Oh, yes.
Okay. Do you feel as though people can understand you all of the time now?
Majority of the time, unless it's my husband, and he'll say, "What? I can't hear you."
Good for you.
But I think he does that just to be cute.
I think he does too. Has anyone commented that it's easier to understand you now?
Oh, yes. I set some of our friends back when we went to their house and I talked loud. Lou says, "What the hell happened to you?" My daughter said, "Oh, Ma, that's you?"
Isn't that good? Don't you feel wonderful?
Oh, yeah, because now she can't say, "I didn't understand what you said."
Right. No excuses, right?
Yeah,
That's
no
right.
excuses.
All right. So what do you do when you want to be as easy to understand as possible?
Think loud.
Okay, so in light of today's presentation, I think it would be useful to bring up a few key points about the Shirley video. One of the things that you would notice is that before she underwent LSVT loud, her voice was quite raspy and hoarse and soft. She didn't use many words, and afterwards you saw this beautiful spread of effects. Not only was her voice louder, but she had nice facial expressions, she was animated, she was able to express her emotions. When she felt happy, she looked happy, and you might have even noticed that her appearance had changed. She took the time to do her hair and makeup, and so there were many changes, and changes beyond even what I mentioned there, but it was through this singular target of focusing on loudness. Now, what I want to point out is that Shirley wasn't too loud, and she wasn't shouting at the end. She worked hard to achieve those results, but it didn't ever get to the point where her speech was so loud that it was abnormally loud or straining or shouting or anything like that. And I just want you to keep her snapshot of her video in your head for when we discuss these myths at the end of the webinar today. So with that, I'm going to forward it to the next video, and this next video is of a gentleman named Bernie, and we just gave you an example of LSVT loud, and now we want to show you an example of treatment effects that one can expect through going through LSVT BIG. Bernie's video is also on our website, so if any of these videos don't play well, they don't play back well because of internet connection during this webinar, please know that you can go to the videos tab on our website and view both Bernie and Shirley and other videos as well. So Bernie had Parkinson's longer than Shirley had at the time of this video and at the time of intervention. He had Parkinson's for 14 years and was a bit more advanced in his disease. And the reason for coming to therapy was because he was having difficulty walking, some falls, his walking was slowing down, he was beginning to have some freezing. And he is also optimized on his medication. So He was at the peak of what his doctor thought was optimal dosage, and his medication dosage didn't change over the 4 weeks. Also, the timing of the videos was timed at the same time in regards to his medication dosage. So in the video, you can go ahead and play it, Beth. On the left side, you're going to see Bernie after his first session of LSVT BIG, and at the last, on the right side, you're going to see him after his last visit. So some things that you might notice right away about Bernie is that, of course, he's not using his cane 4 weeks later. And not only is he not using his cane, but he's walking faster with longer steps. He's swinging his arms a bit more. He has no difficulty getting through that door and over the rug, which is a very common freezing trigger for many people with Parkinson's disease. And so all of this increased speed allowed Bernie to walk a much greater distance in the same amount of time. So go to the next slide, Beth. If you look at Bernie's outcomes that were measured by his therapist, this is what she saw. He went from falling once or twice a month to not. You saw from using a cane to no cane. His confidence was rated on a specific rating scale called the Activities, Balance, and Confidence Scale, where a patient self-rates his or her confidence doing a variety of mobility-related activities. So the higher the score, the more confident a person is that they won't fall. I think the most impressive change that I see is the change in his gait velocity went from about 30% of what was normal for his age to 100% of normal for his age. So this meant now that he could keep up with his peers that didn't have Parkinson's disease. And specifically, that was what his goals were related to. He wanted to go to the movies, he wanted to play with his grandchildren, and he wanted to go out to dinner with friends and family. And those seem like very simple goals, but they're very meaningful goals and yet very complex goals, because Bernie has to be able to walk in environments outside with different terrains, perhaps a different lighting at the movie theater, with children that are moving about this way and that way in a crowded environment of a restaurant. So those are very complex goals, but Bernie was able to achieve those. So with that, I'm going to turn it back over to Beth, who's going to go do an overview of LSVT Loud.
All right, great. Thank you, Laura. So we want to get into where did we begin when developing these treatment approaches. So a little background on LSVT. Back in 1987, LSVT began as an idea at the Lee Silverman Center for Parkinson's in Scottsdale, Arizona. Dr. Lorraine Ramig and one of her students, Carolyn Mead Bonatati, worked together and evolved what is now known as LSVT, which stands for the Lee Silverman Voice Treatment. So here we see a picture of Mrs. Lee Silverman. You can see she was in a wheelchair. She had some mobility issues associated with her Parkinson's disease. But when Dr. Ramig first met her, her family said, if only we can hear and understand her. So we realize that it's a major problem for these individuals with Parkinson's and their friends and family members, and also with other neurological disorders as well, if they're having trouble being heard and understood in communication. So while the physical limitations may be challenging, that inability to communicate with the loved one is often one of the most challenging characteristics of the disease. So I'm going to go into some of the kind of statistics and research that's been done on voice and speech with Parkinson's, so we can see kind of the rationale and reasoning for developing this intensive, starting with the speech protocol and then spreading into the LSVT BIG, which targets the movement and mobility. So over 89% of nearly 6 million individuals with Parkinson's disease worldwide do develop voice and speech disorders during the course of having Parkinson's disease. And some of the common characteristics are reduced vocal loudness, hoarse voice quality, monotone in pitch, and imprecise articulation. Those are some of the more classic characteristics that have been documented in research. And these voice and speech disorders can contribute to lifelong frustration, embarrassment, and social isolation. And there's some research that talks about that as well. Some of the more classic medical treatments that have been used alone don't consistently or significantly improve speech in Parkinson's disease. So that would be pharmacological treatments, taking medications, and there's no evidence of systematic improvement in dysarthria, so a speech disorder, owing to dopamine replacement through these drugs alone. Also surgery, so deep brain stimulation is the most common, has also been performed, but this neurosurgical intervention also does not consistently or effectively improve speech in Parkinson's disease. So we're seeing that the drugs don't make improvements, the surgery doesn't make improvements, and so that's where we found this need to develop a protocol or a behavioral intervention that could make improvements in the voice and speech in individuals with Parkinson's disease, because traditional treatments alone were not making those improvements. So in the past, back in 1987, when the research began, the voice and speech disorders in Parkinson's disease were unresponsive to speech treatment. So people did not think that speech treatment could improve voice and speech for individuals with Parkinson's disease. And so back in 1987, there was no effective voice and speech treatment for these individuals, despite some people doing more traditional voice and speech therapy, not at an intensive dosage. So what this means for a patient, we see at the bottom of the slide here in quotes, if I have no voice, I have no life. So there's a huge impact on the quality of life for these individuals who aren't able to communicate effectively. So this slide shows kind of the journey using the research and where we've been and where we are today. So we've been working on LSVT Loud and LSVT Big now. So beginning over 20 years ago, from the invention back in Scottsdale, Arizona, to today where we're in more of a scale-up phase. So what you see here is we've had a series of funding grants from the Office of Education and the National Institutes of Health to run a series of randomized controlled trials to evaluate the efficacy of LSVT and to understand the changes occurring in the speech production system in patients before and after LSVT. So this helps us understand the basic mechanism of change. In addition to this, we're funding to do imaging studies to understand what's happening in the brain of someone with Parkinson's disease when they have successful treatment. So simultaneous to establishing this research base of treatment efficacy and these underlying changes, we're also motivated to scale up access to this efficacious treatment. So on the one hand, we're working to train clinicians so that treatment is available to more patients. At the same time, we're also turning to technology to make it more available, make the treatment more available to both patients and clinicians. So telehealth delivery over the internet is one possibility. And then the National Institutes of Health and the Michael J. Fox Foundation also funded us in a software development so that patients can practice on their own or have easier ways to do follow-up treatment. So you can see with the research, we're working on multiple levels. We're establishing that research base so that efficacy is well established, understanding that fundamental mechanism associated with treatment-related change so that we can continue to improve the treatment. And then we're also turning to ways that we can scale up access so that the treatment that is well established in the lab can also be delivered to patients globally. So I'll be spending more time focusing on LSVT Loud, and then you'll also see how the research has been done with LSVT Big and how these principles that were used with the development of LSVT Loud were translated into the development of LSVT Big. So here I'll turn it over and talk about LSVT Loud. And what I want to talk about first are 3 paradigm shifts that make LSVT Loud different from traditional speech therapy. So how is LSVT Loud different from traditional speech therapy? Well, it's a very standardized treatment protocol. It's also research-based, so you saw the slide with all the research that's been done, and then I'll specifically get into more of that research. And it's a very specific protocol, so they're individualized to each individual patient. So first, one of the paradigm shifts that makes LSVT Loud different is the target of treatment. So the target of treatment is healthy vocal loudness, and that's the only training target. So as Laura mentioned with the video with Shirley, you heard her have a nice healthy vocal loudness at the end of the video. So yes, we target loudness, but it's always going to be within normal limits. It's a healthy vocal loudness level. The mode of delivery is intensive and high effort. So I mentioned in the past, people did not think that voice and speech treatment was effective with Parkinson's, and so people were not receiving treatment very often. But part of the reason that treatment was not effective is because it wasn't done intensively, so it was done at low dosages. With LSVT Loud, patients are given 16 individual treatment sessions in 1 month, so it's 4 days a week for 4 consecutive weeks. The treatment is delivered in a high effort kind of physical exercise mode of delivery. So patients are pushed to their highest effort levels every single session, all 16 sessions of treatment. In addition, they also have homework for that whole month of treatment and are expected to do follow-up exercises after treatment has concluded. So treatment is very intensive and very high effort. And the third kind of paradigm shift with LSVT Loud is a calibration component. So with calibration, we address the elements that get in the way of generalizing treatment effects, so that in the treatment room, a patient may have a great loud voice. We want to make sure that we tap into those variables that get in the way of getting that voice into a patient's home to make it last. So we're generalizing that great loud voice we achieve in treatment and making sure that it walks out the door and that patient now uses that new loud voice all the time in their everyday living. So LSVT Loud has a target of loudness, a mode of delivery that's intensive and high effort, and also has a focus on calibration. So I'm going to talk about some of the LSVT Loud data, so you know what's been documented in research in the past. So this first slide here shows you what we call a cross-system effect. So even though we're focusing on vocal loudness, we've been able to see other changes across the speech production system. So we've established that clinical efficacy and level 1 evidence, and we've seen that impact of loudness across the speech system, as you can see here. We see the impact on the respiratory system, an impact on aerodynamics, subglottal air pressure, and vocal fold adduction, all together working to increase that overall loudness to make an impact on the ear of a listener perceptually, as well as a spread into articulation. So additionally, we also have preliminary data documenting a positive effect on LSVT Loud in swallowing, and also an impact on facial expression. So one of the very exciting areas of work is the area or the impact on neural or brain function. So this slide really shows you that even though we focus on vocal loudness as the treatment target, we see a spread of effects into other areas of communication as well, and that's very exciting. And some of the long-term follow-up, we get some questions about that, and kind of the thinking in the past was that yes, we know you can make changes in the treatment room, but as soon as a patient walks out the door, or this quote, changes in the treatment room disappear on the way to the parking lot. So really the thinking was, what's the point of doing treatment if the effects are all going to disappear as soon as the patient leaves the treatment room? So we did have some research that show the treatment effects lasting out to 2 years. And so this slide will show you some of that evidence. These data were published in 2001 in the Journal of Neurology, Neurosurgery, and Psychology, and they've been deemed as the first level 1 evidence for speech treatment for individuals with Parkinson's. So on the vertical axis here, you see sound pressure level, which is vocal loudness. And on the horizontal axis, you see duration and time over months. So the red line is the line for individuals who received LSVT Loud, and the blue line is an alternative treatment that it was studied against, and it was a respiratory treatment. So if you follow this red line here, so 0 months, here's the baseline. This is where individuals are starting. So you'll see that at pre, and then we'll look at post-treatment, the improvements there. And then we'll also follow it out to 6 months, and then 12 months, and out to 24 months, or out to 2 years. And you can compare it to this blue line, which is the respiratory treatment. So what you see, if you look at this far right side of the graph here, people with Parkinson's who received LSVT Loud were statistically significantly louder 2 years after receiving treatment than the patients who received respiratory treatment. In addition, they were also statistically significantly louder 2 years after treatment than they were at pre-treatment, or at that baseline. So those are the 2 criteria to support treatment as having level 1 evidence. So this helps for the people that thought that, oh, treatment changes are going to diminish as soon as a patient walks out the door. We do have evidence to say that treatment can last at least out to 2 years. And it's not to say that after 2 years the voice and speech problems returned as they were before, but it's just that was when the funding ended for this particular study. So it's likely that changes can continue to improve beyond 2 years as well. So the data are great, but it's always nice to have these quotes from patients. So here are some quotes to support these improvements after receiving treatment. So before treatment, patients come in and might say, if I have no voice, I have no life. So after treatment, they're saying things like, my voice is alive again, I can talk to my grandchildren, I feel like my old self, or I'm confident I can communicate. So those are really the statements that kind of warm our heart and help us continue to do the work that we're doing. So just briefly, I want to show you what an LSVT Loud treatment session looks like. So it's broken up into 2 halves. The first half of the session are called the daily tasks or daily exercises, and they're designed to rescale the amplitude of motor output through core loudness training. So it starts with a sustained ah, so ah, and a loud voice. Next, patients do high and low ahs. So a high ah would sound something like this, ah, and a low ah, ah. So in a loud voice, everything is done in the patient's loud voice. And functional phrases, so these are phrases that patients say every single day. They're asked to say these in a loud voice. And so that takes up the first half of a session or the first 30 minutes of every session. The second half is what we call the hierarchical speech loudness exercises. And these take those core exercises into more context-specific and variable speaking activities. So gradually progressing from week 1 to week 4, from short, simple words and phrases to longer, more complex conversational speech, so that by the end of 4 weeks, individuals have trained at a level where they're using their loud voice in everyday conversation. And again, when I say loud voice, I mean that we're getting a patient's normally soft voice up to a normal loudness level. So it will feel loud to the patient because it's louder than they've been speaking, and that's part of what we're working on with the calibration component. But it's not a voice that's shouting or an overly loud voice. So it's a within normal limits voice that we're targeting. Just like you saw in Shirley in her post-treatment video, her voice was louder than pre-treatment, but it was not a voice that was overly loud or shouting. So I now want to turn it back over to Laura, and she's going to talk about LSVT BIG and some of that data that's been done on LSVT BIG.
Thank you, Beth. You can go to the next slide. So oftentimes we're asked the question, well, how did LSVT BIG come about? Beth talked about the history of research over the last several decades, starting initially with LSVT Loud. And around the year 2000, when LSVT Loud was well established as a very, very effective treatment for improving speech in people with Parkinson's disease, the idea was brought forth by Dr. Becky Farley and Dr. Cynthia Fox, who were working on their PhDs at that time. What if we applied these same principles to the limb motor system? In other words, your body, your arms and your legs that affect your movement in Parkinson's, would it be just as effective? And so then that translation began to occur directly from the LSVT Loud protocol to the LSVT BIG protocol. So much of what we do today in LSVT BIG we owe gratitude to because of all of that research on LSVT Loud. Next slide. The fundamentals of LSVT BIG then are just the same as they are for LSVT Loud. It is also a standardized and research-based specific protocol, but even though it's standardized, we're going to talk today a little bit about how it is also customized to each person's needs. Go ahead and click through. The fundamentals of LSVT BIG are the same as those for LSVT Loud. Instead of focusing on a target of amplitude of voice, we focus on a target of amplitude of movement. So amplitude is just the bigness of a person's movement, because we recognize that with Parkinson's, over time, as those neurotransmitters, including dopamine in the brain, are depleted, movement becomes smaller and smaller over time. And this affects not only things like walking, but also fine motor skills like handwriting or buttoning, for example. The mode of LSVT BIG is intensive and high effort. It is a standardized treatment protocol that's delivered 4 times a week for 4 weeks because patients need a lot of repetition of practice for motor learning, especially in Parkinson's disease. High effort is needed because simply for one reason, it takes much effort to override this tendency to move slow and move small that is part of the symptomatic pathology of Parkinson's disease. So there's a great rationale, much more complex than we can explain here today, of why the mode needs to be intensive and high effort in order to be efficacious. And the last of those fundamentals is called calibration. And Beth mentioned that we don't want those treatment effects to just walk out the door. Traditionally, in therapy years ago, and especially personally prior to delivering LSVT BIG to my patients, unfortunately, this is what I found, is that I was effective at getting patients moving bigger and better in the treatment room, but it was difficult to get them to carry over. And so with LSVT BIG, we very strategically and specifically work on this idea of sensory calibration so that the patient feels what it feels like to move more normally again with normal amplitude that's not too small, so they can replicate that on their own. We work very repetitively so that the patient can get to the point where they can internally cue or they can remind themselves to use that bigger movement throughout the day. And lastly, we work on things like ability to dual task, to shift what we call cognitive set, to move big in one situation and then transfer that learning to another situation. So all of those words you see there are barriers to calibration that we very specifically address in LSVT BIG, and it's very, very unique to the LSVT protocols, but also is what makes the LSVT protocols very effective and long-lasting. Next slide. I'm going to briefly go over some of the data on LSVT BIG. Next slide. One of the randomized control trials that was done came out of Berlin, so we affectionately call it the Berlin BIG study. It was published in Movement Disorders in 2010. And in this study, if you're not familiar with it, they took 60 patients with Parkinson's disease and randomized them into 3 treatment groups. On the left, you see 20 were in the LSVT BIG group that was delivered 4 times a week for 4 weeks. In the middle, you see 20 were in a Nordic walking group, because Nordic walking is a traditional form of therapy intervention in Germany. They're very fitness-oriented, outdoor-oriented people, and so they go out in groups and work on big arm swings with their walking poles, big strides, complex environments, and Nordic walking is something that has been supported as a treatment for Parkinson's disease. And the last group is a home exercise program group, and this is the only group that was not supervised by therapists. They were given instructions on advised exercises to do for specific deficits associated with Parkinson's, and then were encouraged to do the exercises daily on their own. So both the Nordic walking group and the LSVT BIG group were prescribed and delivered 16 sessions of supervised exercise delivered by one physical therapist. LSVT BIG was 4 times a week for 4 weeks, and Nordic walking was twice a week for 8 weeks. We'll go to the next slide. The primary outcome variable that they studied in this Berlin BIG study was the UPDRS motor score. The UPDRS is a rating scale that many physicians, especially movement disorder specialists, use to rate disease severity, to rate changes in symptom management as a result of medications that the patient might be prescribed by the physician, and so on. And so in this rating scale, the motor score, a drop in the number or a decrease in the number signifies an improvement in motor function. You can see in the graph that the dark thick line is the home exercise program group. The dotted line on top is the Nordic walking group, and the dashed line on the bottom is the LSVT BIG group. So you can see that after 4 weeks, which was the end of the LSVT BIG treatment, their UPDRS score had dropped by around 4 points, even a little bit greater, which was an improvement. These patients were followed up to 16 weeks post-intervention or post the start of the trial. And I think a couple of interesting things. One, the LSVT BIG group continued to improve even beyond the 4 weeks of intervention, presumably because they continued to practice their daily exercises on their own, whereas the Nordic Walking group and the Home Exercise Program group actually got a little bit worse in their UPDRS scores. The amount of change, which is 5 points on the UPDRS score, was statistically significant when compared to those other Nordic Walking groups and Home Exercise groups. So it's quite exciting, and 5 points is what we would like to see when researchers are investigating new drugs for Parkinson's as well. So Dr. Ebersbach and his team and of course all of us are very excited because it leads us back to the statement of exercise is like medicine. Next slide. The LSVT BIG treatment protocol is structured like this. Our patients do, on the left side, daily exercises, and there's 7 different ones that work on movements in all different directions, forward, backwards, sideways, and rotational movements to help the patient learn how to move bigger. Then those big movements that they learn are then translated into function, and you can see on the right hand of the slide functional component tasks, walking big, and hierarchy tasks. And this is really where we say, okay, do you remember how you moved big in that specific exercise? Now we're going to practice these functional tasks that are important to you, meaningful to you, and we're going to practice them in a big way so that they're more normal in amplitude as they were prior to you having Parkinson's disease. And so our goal is by the time the patient has completed LSVT BIG, they can not only be independent with their home exercise program, but they're independent and able to internally cue themselves in a walking pattern that's normal and in functional tasks that are normal, like being able to, for example, get in out of bed with normal speed and normal amplitude. Or maybe for someone that's newly diagnosed, it means that they can get out there and play golf and keep up with their golf partners, maintain their golf swing, walk over all different types of terrain, etc. So in this part of the treatment session, it's very much customized from patient to patient. Next slide. So now I'm going to turn it over to Beth, and we're going to talk more specifically back and forth about myths regarding the LSVT protocols, and I think we'll just kind of both talk and ping-pong some of these questions back and forth.
All right, great. Thanks so much, Laura. So these first 2 pertain more to LSVT loud, and we've kind of addressed them during the presentation. So I'll just briefly explain these so that we can get to some of the other questions that haven't been addressed yet. But the first myth that we often hear is that LSVT loud trains people to shout. So as you've heard from the presentation, you heard in the video, LSVT loud is training people to use a louder voice than they're used to using. But it's a voice that's within normal limits loudness. So we never train our patients to use a voice that is shouting or a voice that is overly loud. So it's always within those normal limits for loudness. To the patient, it feels like a loud voice or feels like shouting, especially early on in the treatment sessions. But as treatment progresses, they become more and more comfortable with that voice through that process of calibration. So now by the end of treatment, the goal is that patients are able to use this new louder voice more automatically in daily living. So the next one, LSVT loud does not help articulation, only amplitude, or another word for that would be the loudness. So we saw that spreading of effects. We heard it both in Shirley. We were only training loudness with her, but her articulation also improved. And then on one of those slides, you also saw where we have a spread of effects into other areas of communication as well. So even though the focus is on loudness, we also saw a spread of effects into articulation, which was one of those other components of communication, as well as some other areas of communication as well. So again, the focus is only on loudness as the target, but with that target of loudness, we do see that spread of effects. So we've had patients that will come to us and say, I don't feel that I have issues with loudness, but I do have I do have issues with articulation. Or even during the treatment sessions, they'll say, I don't think we need to work on loudness. My real concern is articulation. So we let patients know that articulation will improve if you focus on loudness. So that's under the umbrella of being loud. You're going to see improvements in articulation as well. So just those first couple myths with LSVT Loud that we've talked about in the presentation here today. And then I'm going to have Laura address these next questions. So LSVT Big will make me look ridiculous when I move big. Laura, if you can touch on that.
Yeah, so that commonly we hear that in the initial maybe week or so of treatment is that to the patient it feels like we're making them walk really ridiculously big or move ridiculously big, but our end goal is that our patient will move normally, and that's what we train. We use the word big a lot, but really it's just a word to drive a patient's motor output. There's a sensory deficit that comes along with Parkinson's, and so more often than not, patients with Parkinson's don't realize how small their movements have become until we videotape them or show them. So big is just a word to drive amplitude, much as if you had a thermostat in your house that was very, very cold. You know, maybe it was only 60 degrees in your house, even though it was 70 degrees. If you yelled at that thermostat and said hotter, 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 you don't necessarily want it to be hot in the house. You just want that temperature to be just right so it's comfortable, so it actually is 70 degrees. The next one is LSVT Big does not help with fine motor skills. Again, we use the word big, but even small movements are too small in Parkinson's disease, and it's easy to see when you think about micrographia or handwriting that becomes very, very tiny. So we don't want to cue or train handwriting that's so big that it takes up many lines, but we do want to drive handwriting so that it's big enough to be considered normal and big enough to be considered legible. And the same goes with other fine motor tasks such as buttoning, putting in earrings, doing your zippers, everything like that. Next slide.
Right, so this next one, so insurance will not reimburse for something as intensive as LSVT Loud or LSVT Big. So I'll just start out by saying we've had great success with reimbursement for both of these treatment protocols. Because there's so much evidence behind them, that can really be helpful to, especially as clinicians are just getting started. If they need to provide that evidence to insurance companies, there's over 20 years of evidence, as you've seen here, to support the treatment. So that can be a really helpful base, just to know there's so much evidence to support it. This is why we did the treatment. So with reimbursement, we also say that it's helpful to get when clinicians or patients are working with their neurologist or their primary care doctor, if they can do a prescription for a evaluation for either the speech therapy or the physical or occupational therapy, and then also the 4-week treatment protocol, that can also help with reimbursement. So that's kind of just a tip that we have. And when clinicians do our training to become certified, they learn a lot about the reimbursement tips and how to be as successful as possible. Another question that comes up regarding reimbursement for individuals with Medicare is they say, well, I have this Medicare cap. There's this somewhat new Medicare cap, which I'll go over if I do LSVT Loud or LSVT Big. So there is a code, so clinicians are also trained on coding that they can use, or I should say a modifier that they can use when they're documenting and seeking reimbursement, and that can help them go over that Medicare cap. So that's something else to keep in mind. The bottom line, I would say, with reimbursement is that insurance companies do pay for the treatments. So it does seem intensive and it's not traditional therapy, but having that evidence to support why clinicians are doing it is one of the big reasons why we have had great success with reimbursement. Some people do get denials, but you can also fight those denials, and I'd say almost all of the time the clinician or the patient does win that, and then is able to get reimbursed. And sometimes it's as simple as a coding error, or just not proper documentation. So it is important that clinicians are documenting very clearly. And what's really great about the protocols is the treatment programs are quantifiable. So it's easy to write these treatment goals and have very quantifiable measures to see if the patients have been achieving the goals along the way. So my bottom line answer is to say that treatment is very reimbursable. And Laura, I don't know if you want to add on to that at all.
Beth, I would just say the same. You know, if there are patients listening, know that usually where there's a will, there's a way. Sometimes clinicians have to appeal, but overall we've had very, very successful reimbursement patterns with all types of different insurance with LSVT BIG. So I wouldn't ever be shied away from offering LSVT BIG to my patient because of potential insurance questions that I might have.
All right, great. Thanks, Laura. So now we'll talk about some accessibility myths. So in rural populations, it's not feasible for people to make that lengthy commute to clinic 4 days a week. So with LSVT Loud, I'll speak more specifically to that and then turn it over to Laura for LSVT Big. But we have turned to technology as one way to help for patients that are living further away. So as I briefly mentioned before, we do have a telehealth delivery approach called LSVT eLoud, and that's where sessions can be done over the internet. So there's been research done to support that the treatment done over telehealth was as effective as treatment done in person. So patients can do all 16 sessions over telehealth, or they can do some of the sessions over telehealth and some of the sessions in person. Some of it just depends on licensing regulations for clinicians in your state. For example, I was licensed in Texas, and in Texas you have to see the patient in person first for the evaluation, and then you can do all treatment sessions over telehealth. So that's just something to keep in mind if there are clinicians out there that are thinking about doing telehealth delivery. The other possibility with LSVT Loud is to use the LSVT Companion for some of the sessions. And a research study was done. The LSVT Companion is a software program that actually can run patients through treatment or homework sessions. So the research study that was done, the clinician alternated, I shouldn't say alternated because it wasn't exactly alternated. The upfront, more of the sessions were done in person. I think the whole first week, all 4 sessions were done in person, and then gradually introduced the LSVT Companion for at-home treatment sessions. So in total, 9 of the sessions were done in person and 7 were done using the LSVT Companion independently at home. And the results for that research study also were very comparable to the in-person for all 16 sessions. So that's another possibility that the patient could purchase or the clinic could loan out the LSVT Companion to the patient to use for some of the sessions at home so that the patient isn't having to come into the office all 16 sessions of treatment. We also have had patients who are willing to just commit to a month of treatment, and maybe they come and stay at a hotel or with a friend nearby to a clinician for a month, and then they can come into the clinic every day that way because they're much closer to the clinic. So those are just a few ways that we've helped make LSVT Loud more accessible to patients in those more rural populations. And Laura, I don't know if you want to speak to LSVT Big for this. Okay, sorry, I think we were having a connection issue, but I hope that you're all able to hear me again. And Laura, if you'd like to touch on that first bullet point
Yeah.
on the slide here for LSVT BIG.
Yes, I think I might have lost you, but basically, can you hear me now, Beth?
Yes, I can hear you.
Okay. Yeah, so basically what I was saying is that, coming from a rural area, even though we don't have telehealth for LSVT BIG, oftentimes patients indeed were willing to commute when they were presented with the evidence and the value of LSVT BIG. And so I had a couple of patients that did that and didn't regret it at all because the treatment effects that they gained were so great for their improving their quality of life. So I would, it's not for everyone, but I definitely would consider it if I myself, I know, had Parkinson's disease.
All right, great, thanks Laura. And if you want to start with this next one, LSVT loud and LSVT big can be delivered at reduced dosages.
Yes. So LSVT big, we don't have any data right now that supports delivery at a reduced dosage, and we feel fairly strongly that we need that repetition and that intensity to gain the treatment effects that we found in the treatment studies that LSVT is so well known for. And Beth, if you want to talk about LSVT loud and that other study, you sure can.
Yeah. So yes, so LSV, neither of the treatment protocols should be modified to have a reduced dosage. I just want to kind of start with that to make sure that everyone knows that there is a very standard protocol and a standard dosage for both LSVT loud and LSVT big, and that's what's been researched, so that's what we know works for the treatment protocols. There was a study that looked at a protocol, or I guess a kind of an adaptation to the dosage called LSVT-X or LSVT extended, and that's where treatment was delivered, and this was only for LSVT loud. Treatment was delivered 2 days a week for 8 weeks versus the 4 days a week for 4 weeks. And it also had good results. So patients were had similar results to when they were seen for the 4 days a week for 4 weeks. So kind of the catch with that, and we do really caution clinicians who want to do this version, is that even though they were seen 2 days in the clinic, they still had at-home practice every single day for those 8 weeks, and they had very personalized, individualized activities for them at home. Clinicians were still checking in with them every day. So we did that in a research lab. The clinicians that were on that study had plenty of time to get all those treatment materials, all those homework materials, to do all those homework assignments for the full 2 months. So it's a little harder to adapt that into a clinic environment. So that's why we do kind of caution, or really we just kind of provide some more information about LSVTX, and we'd have you read that paper so you can get some perspective from the clinicians before diving into that dosage, because even though it did have good results, it is important to know that there was still a lot of outside work that had to be done that would be harder to do in more of a clinic environment. All right, so the next one, Laura, if you want to start with this one, I only work part-time, so I cannot deliver 16 sessions of treatment in 1 month.
Yes, and so this does happen sometimes. As Beth said, the dosage cannot be reduced. And what we often recommend to clinicians is that they find someone else that they can partner with, or in some extent job share with, so that LSVT BIG can be delivered. And training is really easy now because it can be done online, and a clinician can get trained up in as little as 2 days, anywhere, anytime, through our online training.
All right, great. Thanks, Laura. And I just want to make a comment before we go on. I know we're just about at our hour here, and so Laura and I will stay on to make sure we can address the rest of these myths and any questions that come up. But if you do have to sign off, we are recording this webinar, and the recording will be available on our website. It should be posted within 48 hours. So you can always go in and listen to the recording again, and you can jump to the end of it if you do have to sign off but wanted to hear some of the end of the presentation here today. So the next one on this slide, it's too intensive and patients will not be agreeable to come 4 times a week for 4 weeks. So I will say a lot of times we get patients who are just very motivated. They've heard the research about the treatments or they've seen videos and they're motivated to come in and they're very willing to come in for those 16 sessions. We have certainly had patients that are more resistant, or it could possibly be that their spouse has kind of forced them to come in, or maybe they've received this prescription from their neurologist, but they really don't think they need it, but they wanted to follow through with that anyways. So we've certainly had that as well. And what I found with LSVT Loud is patients may come in like that, but then as soon as they begin treatment, they're very motivated because they can see right away that the treatment does make a difference in their life. So that's one thing I would say, is even if patients don't have motivation right away, as soon as they get started, I see that motivation really change. Another point that I wanted to make with this was that sometimes you can't commit to a month of treatment right away. So it might be that you find out about the treatment, you're ready to do it, but maybe like right now would be a bad time because it's the holidays, so you can't commit to 4 weeks. So then you plan out, okay, I have the Christmas holiday and then we're going on a trip in January, but I can really commit in February. And so then a patient would commit in February when they do have that time. And so clinicians are very upfront during the evaluation, letting patients know the intensity that it will be, and then also that it will require homework every day in order to work. So it's important to get a month that you are able to commit to the treatment protocol. And Laura, I don't know if you wanted to add on to that at all.
No, that's perfect, Beth. I just think I always give my patients the benefit. Are you there, Beth?
Yes.
Okay, did you hear me?
Yes.
Okay, perfect.
All right, so the next one, so application myths, we'll talk about some of these. So LSVT Loud and LSVT Big only work with adult populations. And Laura, if you want to start on this one.
Sure. So for LSVT BIG, the research has only been on adult populations. However, as part of the training, the clinicians are taught how to assess for application to other disorders. So in adults, that includes different types of atypical Parkinsonism, sometimes stroke, and we had lots of recent questions actually about application to developmental delay, autism, and Down syndrome. So we look forward to some future potential research, and if you have a disorder that you're interested in, it never hurts to ask the LSVT BIG clinician or LSVT Loud clinician about it, because they know how to do specific testing to determine if that would be an appropriate intervention or not.
Yeah, and so the same situation applies with LSVT Loud. Clinicians are trained during the evaluation to see if a patient would be appropriate for LSVT Loud. There has been research done on kids with Down syndrome and cerebral palsy. We don't have as much research as we do with people with Parkinson's, but the research is very promising for those populations. So still with those populations, a clinician would do stimulability testing as part of the evaluation to see if the treatment would be appropriate, but those are two populations that have been studied in pediatrics for LSVT Loud. The next one is pretty similar. So LSVT Loud and LSVT Big are not appropriate for all stages of Parkinson's disease. So just like trying these programs with pediatrics, for individuals that have later stage Parkinson's disease, or maybe even Parkinson plus, or just kind of a more severe neurological disorder, during the evaluation, the clinician would do stimulability testing to see if a patient would respond well to the exercises that we do in LSVT Loud or LSVT Big. And if clinicians do like what they see, they'll work with the family to see if the family would like to go ahead and progress with treatment. With these programs, though, sometimes with patients that are further along in the disease, or maybe are a Parkinson plus or more severe, we may modify the end goal of treatment. So for individuals with Parkinson's, stages 1 through 3 on the Hoehn-Yahr scale, the end goal is always that patients can use this new loud voice in everyday conversation, and that's the end goal, that they use that loud voice all the time. For people in later stages of Parkinson's disease, it might be that by the end of treatment, they can use their loud voice at a phrase level, but maybe they need some external cueing to be able to use that loud voice in other types of communication situations or for longer speaking situations. So it can certainly be used with people with later stages of Parkinson's disease, but it may just be that the end result or the end goal of treatment would be lesser than for those who have stages 1 through 3, for example. And Laura, if you want to take this next one, she's really been a leader in this question on treatment can be delivered in groups. So can treatment be delivered in groups?
Sure. So LSVT Big and LSVT Loud as treatments are always delivered in a one-on-one individual treatment way. And there's good rationale for that. It's a skilled therapy treatment, but it's very, very much customized to each person's needs, their abilities, their goals. So for LSVT Big, for example, I said that we do a set of maximal daily exercises, but the performance of those exercises varies differently from person to person. For someone that's very young and high functioning, we might be doing them on balance pads with weights. We might be doing what we call dual task challenges. And for someone with more advanced Parkinson's disease or more severe mobility and balance issues, we might need to give them something to hang on to for support. We might need to steady them with a belt externally. So the performance of the exercises varies from different person to person, and also, more importantly, the functional application varies from person to person. So one person might be working on a very specific functional set of tasks, like the ability to get her socks or shoes on, or the ability to get out of a really low chair, or the ability to transfer in and out of a bed, managing covers, rolling over, etc. It needs very direct and specific instruction and cueing for that person, while the other person might be entirely different and have a whole different set of functional tasks that they're working on. So it would be impossible for the therapist to devote the full attention and give instruction to even two people simultaneously at the same time. Now, after treatment, after discharge, and the patient has been successfully discharged from LSVT Big and LSVT Loud, then it's possible to organize a group of patients who has completed them and can practice their exercises in a group setting together. And we're actually working on development of a formal program called Big for Life and Loud for Life that'll be launched this spring, so that participants of LSVT Loud and LSVT Big can come together and meet in these groups, and it'll serve not only as an exercise group, but I think somewhat of a support group as well.
All right, great. Thank you, Laura. Some other myths that we have here. So I was just diagnosed and don't have any problems with my voice, mobility, or balance. So we do hear from individuals who think that they don't need to come in for treatment because they just got a diagnosis, and maybe they don't even have some of these overt symptoms yet. So our dream is really that individuals would receive treatment as soon as they were diagnosed with Parkinson's, because even if you're not seeing some of those more overt symptoms, we can help to maintain the level of function where you are. So that's one way to look at it. Another way is you might not be noticing the changes, and we can kind of tease apart some of those changes. So specific to the voice, it might be that your voice is fine in more of a one-on-one situation, but if you speak for longer periods of time, or if you speak in a group, or if there's a lot of background noise, then maybe it is more difficult to hear you, and that's something that you haven't noticed yet. So we encourage everybody upon diagnosis to receive the treatments to again either maintain the level of function where you are, or to really help you first see that there is an issue with voice mobility or balance that you weren't aware of, and to make sure that you can now improve those areas and then hopefully maintain that improvement for longer. So yeah, so I would say even if you're just diagnosed, we want to see you. So we would encourage you to talk to your neurologist about getting a referral for an evaluation and treatment.
And Beth, the same goes for mobility aspects as well. Oftentimes patients that are very early in their diagnosis don't recognize changes like diminished arm swing on one side, or maybe even subtle changes in balance because of the sensory problems with Parkinson's disease. But sometimes those are more apparent if a person is anxious, stressed, is dual tasking, and so on. But furthermore, we have to always go back to the literature and remember that even at diagnosis, the neuropathology is quite significant in Parkinson's disease. They say that about half of the dopamine production cells are lost at stage 1, at diagnosis, when those symptoms first appear. And so if we can say through intensive voice and body exercise that we have the potential to slow disease progression and, you know, make some of those nice neural changes, our chances are much greater earlier in the disease than later in the disease. So I just encourage anyone that's newly diagnosed to sign up because earlier is better.
All right, great. Thanks, Laura. So if you want to take this next one, I'm very physically fit and exercise often, so I don't need LSVT BIG. Yes,
that's a great question, and I hear that, I've heard that more than once. And what I would say to persons that say that is, that's excellent. You're a step ahead of most people, and continue being physically fit. Continue doing the exercise that you love as intensively as you can handle it. But that doesn't mean that you don't need LSVT BIG, because LSVT BIG specifically works on the deficits of Parkinson's, that bradykinesia and hypokinesia. And we've had plenty of people that have gone through LSVT BIG that were newly diagnosed early in their Parkinson's disease, and unfortunately quit doing their LSVT BIG exercises but continue doing their regular exercises, whether it was you know, lifting weights or running, or we've even had marathoners, but their symptoms progress when they don't do their LSVT BIG exercises. Their movements tend to get smaller again, even though physically and cardiovascularly they're fit. So I think it's important to have a combination of both intensive amplitude-based exercise, in this case LSVT BIG, in combination with daily other exercise, whether it's aerobic, yoga, tai chi. There's many different and excellent forms of exercise that one can do.
All right, great. Thanks, Laura. So the next one, I've had big or loud for a few sessions and it did not work. So that the wording in here for a few sessions should really be the kind of the key to focus on here. If you've only had it for a few sessions, then it's not going to work, and you didn't actually receive LSVT BIG or LSVT loud if it was only for a few sessions. In order for the treatments to work, they have to be just as they were done in research, so that 4 days a week for 4 weeks at that intensive dosage, 1 hour individual sessions. Or you cannot expect the same results that we've been able to see in the research studies. So if you have had big or loud for just a few sessions, I would encourage you to go back and find a clinician that is certified in LSVT loud or LSVT big, and make sure that you're getting all 16 sessions of the treatment to make sure that it does work. And when you are searching for a clinician, that's one of the questions that we would have you ask them when you're looking to find someone to do treatment with. You would ask them, do you do the standard protocol, and make sure that they do tell you that they do it 4 days a week for 4 weeks for 1 hour individual sessions, again to make sure that you're getting the treatment protocol that's been studied in research, and we've been able to see those positive results. All right, and Laura, if you want to take this last one. So LSVT loud and LSVT big are just a simple set of exercises that you can learn from the homework helper DVDs that are available through our website.
Yes, great question, and unfortunately I think I've heard this from a few people. I just recently heard this from a person that was got her hands on a handout of the home exercises and had the misunderstanding that that was all it was about, and then came to one of our patient symposiums, learned more about LSVT BIG, and realized how much more complex this treatment really is. And I think if you remember back in the slides where we were talking about application to function, you know, actually not just learning the exercises which we would consider stepping stones or building blocks to improve movement, but then applying them to functional tasks and really practicing those bigger movements or a louder voice and function is so important, and something that you can't do on your own. It's something you need skilled therapy for, you need feedback, you need repetition of practice, you need a therapist in your face that's going to be encouraging you and progressing your treatment over the course of 4 weeks or more that you see your therapist. So if you have a homework helper DVD, it's wonderful. Our LSVT Big Homework Helper DVDs are great adjuncts. They're great treatment tools so that when you're going through treatment and when you're finished with treatment, they really help to keep you motivated so that you can continue to do your exercises every day, just like your daily dosage of medicine, but they should never replace skilled intervention by an LSVT Loud or LSVT Big certified clinician.
All right, great. Laura, thanks for clarifying that. And so that goes through our myths that we have, some of the common misconceptions or questions that we get regarding the treatments. So now that we've talked all about LSVT Loud and LSVT Big, we want to make sure that if any individuals out there are interested in receiving the treatment, how you go about doing that. So the first step would be to talk to your doctor and ask for a referral and possibly a prescription for speech and or physical and occupational therapy for both an evaluation and treatment. And again, that can really help if you get that prescription to help with reimbursement purposes. And then on our website, so lsvtglobal.com, we have a Find a Clinician button that you can click, and then there you can search for LSVT Loud or LSVT Big certified clinicians in your area. And lastly, we have some DVDs that Laura was just talking about, so those homework helper DVDs, which can introduce you to these programs with by going over some of the exercises that you'd be doing in your treatment sessions. So again, those DVDs cannot replace treatment, as Laura was mentioning, but they can be a great tool to help you kind of get started with what the exercises will be like, and they can also be great during treatment to help you with homework, and after treatment to make sure that you continue to practice the treatment approaches or the treatment that you're working on. So if you do have any other questions, we do encourage you to email us, so info@lsvtglobal.com, and we're always happy to take those questions and make sure that you get your questions addressed. And we'll display, or I should say we'll post this webinar to our website shortly so that you're able to view the recording again if you would like to do that. And we'll send a follow-up email as well with the handout attached in case you weren't able to access that during the webinar. So thank you so much to everyone for joining us. Thank you, Laura, for a great webinar and your expertise here today. And we hope to see everyone again on a future webinar.